Hello, I'm Dr. Lawrence Prokop, Professor of Physical Medicine and Rehabilitation at Michigan State University College of Osteopathic Medicine. Today we are going to discuss pain issues and how they are pertinent in the speech and language pathology realm. Pain complaints are some of the most common complaints seen in a doctor's office. They often are not the primary concern, as there are other medical, surgical, or rehabilitation needs for the patient. Therapists, including speech and language pathologists, may be the first clinicians to hear or see the effects of the pain complaints, and thereby may aid the physicians and the other therapists in treating the patients by drawing attention to these concerns. Painful conditions can be a block to progressing with the rehabilitation efforts in the patient. They can block the ability to move and the desire by the patient to participate. We must identify the cause of the discomfort, if at all possible. We usually see two types of discomfort. One, physiologic, where the pain is related to physical injury or abnormality, and the other being psychologic, where the pain is related to emotional stress. This may feel like and or coincide with physiologic pain. Physiologic pain will have a number of potential causes, such as premorbid conditions, direct injury to the tissues, secondary injury to the tissues, compression from bracing, wheelchairs, prosthetics, also effects of central nervous system or peripheral nervous system injury, hypersensitivity from prolonged opioid use, and complex regional pain syndrome. Premorbid conditions are conditions that exist prior to the accident or illness that brought the person into the rehabilitation care. Examples of this could be arthritis, causing joint pain, a short leg syndrome, causing abnormal gait, causing chronic strain on the low back, and thereby giving low back to even upper back and potentially even headache pain. Scoliosis, from various causes, including idiopathic and trauma. But scoliosis can exist throughout a person's life, and this constant strain pattern in the spine and the paraspinal muscles can develop into painful conditions. Direct injury to tissues can be of a number of different types, including tendinitis or inflammation of a tendon, neuralgia, painful nerves, capsulitis, where the joint itself is painful, arthritis, where there is change in the architecture of the joint and the chemical activity in and around the joint, and scar tissue. Secondary injury would be trauma that comes after the primary injury or illness that brought the person into their rehabilitation care. This would include things such as compression from prosthetics and orthotics and durable medical equipment, overuse from therapeutic exercise, sprain strain injuries from contracted muscles and contractured joints. Effects on the central nervous system and peripheral nervous system can often be seen in neuralgia or painful nerves and spasticity or hyperactive reflexes and contraction of the muscles due to the central nervous system injury. We will sometimes see a hypersensitivity from long-term opioid use. Exogenous opioids, that is, opioid medications taken into the body, will suppress the endorphins or the naturally occurring morphine-like substances within the body. There's a potential to permanently suppress the endorphins if the opioids are taken for too long and at too high a dose. Complex regional pain syndrome is a condition that has existed, that we have known about since the Civil War. It has gone by many different titles, including the current most common complex regional pain syndrome, but also reflex sympathetic dystrophy, causalgia, and shoulder hand syndrome. Early on, trauma will cause vasospasm, and the trauma may be a direct injury to the body or a trauma such as a stroke. The patient develops the vasospasm with decreased blood flow to the nerves, which develops into neuralgia or painful nerves. There's early swelling in the tissues, but later on in the disease process, the tissues will shrink. There's muscle spasm, joint contracture, the skin becomes thin, and there can be severe pain with movement of the limb. One of the diagnostic indicators is often allodynia. This is a hypersensitivity or pain to non-painful stimuli. The patient may complain of severe pain in the hand just from wind blowing across the hand. Psychologic pain has several characteristics, including hesitancy of movement due to fear of causing repeat injury or trauma. The patient may have a possible flashback to the cause of the injury and have a fear of re-injuring the previously injured area or operated area. Therefore, the patient does not want to participate in certain activities that the patient feels may recur the pain complaints. This may require psychological intervention and the possibility of psychological evaluations, such as the Minnesota Multiphasic Personality Inventory and Beck depression testing. Acute pain has various characteristics. It is generally due to medical changes, trauma, and even chronic posture. We generally see early on an erythema or redness of the skin and an increase in temperature in the skin. There's frequently a swelling in the area of the injury or illness. We see immobility, muscle spasm, decreased movement, which causes decreased synovial production in the joints, capsular contraction, pain in the joints. Then if we try to move the joints, and this pain causes more muscle spasm, decreased joint movement, further decreased synovial joint fluid production, and further capsular contraction, and a progressive spiraling down of the patient's function. Acute pain also has an initial elevation in heart rate quite frequently. Arterial oxygen pressure will frequently decrease, but this is generally transient. There's an increase in stress hormones such as epinephrine and norepinephrine circulating in the body. And this is usually due to A delta nerve fiber transmission carrying these sensations. Chronic pain has some different characteristics. We see immobility with the chronic pain. We also see decreased synovial fluid coincident with the immobility and capsular contracture starting in 24 to 48 hours of immobility. But we generally do not see inflammation. There's generally a normal heart rate and normal arterial oxygen. There is normal epinephrine and norepinephrine, and we often have a burning or sore sensation, which is generally carried through C fiber nerves. Opioid effects have beneficial effects to the patient. There's analgesia, where the opioids will block the sharp A delta fiber type pain. Unfortunately, in many patients with too long or too much opioid, they risk dependency and even addiction. The opioids act exogenously, that is, from the outside to the inside of the body, and will decrease the endorphin production, blocking a feedback loop within the body and making pain complaints more severe because the body cannot produce their own pain fighting chemicals. So the perception of the pain can go up even without a change in the etiology of the pain. It is suggested that there is a permanent suppression, or could be a permanent suppression, of the endorphins with prolonged opioid use. Endorphins are defined as endogenous morphine-like substances, and they are also called endogenous opioid neuropeptides. They're produced in the central nervous system and the pituitary gland. There are multiple types, including alpha, beta, gamma, delta, and others. They inhibit transmission of pain signals throughout the nervous system. A side effect of the endorphins is that if utilized, if stimulated enough, they can cause a euphoria. Endorphin production is blocked by opioids. Endorphin production, however, can be stimulated by endurance activities, laughter, and medical acupuncture with a low frequency, high amplitude stimulation. It is felt that a runner's high, where the runner feels that they can run through a wall of sensation and then feel like they can run forever, that runner's high is actually an endorphin response where the endurance activity markedly increases the endorphin deposition in the body. Let's talk about treatments for pain complaints. There are a number of different treatments used primarily in acute pain. Oral medications such as acetaminophen gives an analgesic or pain treating effect and an antipyretic effect, but not an anti-inflammatory effect. Non-steroidal anti-inflammatory drugs such as ibuprofen and naproxen are also analgesic and also antipyretic, that is, keeping temperature down, but they are also anti-inflammatory, bringing down swelling, redness, erythema in the skin, and they have an anti-platelet effect also. Oral steroids are also used. They have a very powerful anti-inflammatory, swelling, erythema decrease effect. Primarily in chronic pain, we will use antidepressant and anticonvulsant medications. These are often used to treat neuropathic pain. In neuropathic pain, we see dysesthesias, abnormal sensations, not sharp or lancinating pain, but burning and aching, throbbing dysesthesias, and an allodynia, that discomfort to non-painful stimuli. So in neuropathic pain, we'll often see burning, pins and needles, and cold sensations. These medications will function primarily at the neurotransmitters. They're descending from the brain down the spinal cord, inhibitory pathways, moving from the brainstem to the nociceptive pathways in the spinal cord through the dorsal horns. And these medications will help to block the transmission of these painful sensations through this system. Some of the medications that are used for this are tricyclic antidepressants, such as amitriptyline, serotonin reuptake inhibitors, such as Zoloft, gabapentin or Neurontin, pregabalin or Lyrica. Gabapentin and pregabalin are anti-seizure medications, anticonvulsants. A current favorite right now is duloxetine, or Cymbalta as the trade name. This medication is an antidepressant, but has great effect on musculoskeletal pain complaints. Many times we will want to treat the patient with various injections. The medications we use are generally local anesthetics and steroids. We may require some mechanical guidance, though many injections, especially superficial nerves, many joints, and some muscle injections such as trigger point injections, we can perform without mechanical guidance. But if needed, there are nerve stimulators, ultrasound units, and fluoroscopy radiology units that can help to localize to the structure we want to address so that we can inject right at that structure. The idea is to break the cycle of pain. Decrease the discomfort with peripheral nerve blocks, with joint injections, muscle injections, and tendon injections. Common medications that we use from left to right on the tray here would be triamcinolone, a short-acting anti-inflammatory steroid medication. Bupivacaine, a longer-acting local anesthetic. Ethyl chloride, which is a spray which is sprayed on the skin, and it's called a vapocoolant. It evaporates, cools the skin, and that causes some anesthetic effect, and that will help decrease the discomfort of the injection itself. Lidocaine is a relatively short-acting local anesthetic. Methylprednisolone is a relatively long-acting steroid medication, and we will generally use betadine or some other medication to cleanse the skin prior to the injections. Commonly, we'll use syringes and needles, sizing chosen appropriately for the specific structure we're injecting and for the patient comfort. Our medications, again, will cleanse the skin with alcohol, betadine, or Hibiclens. We'll use Band-Aids and cotton balls for hemostasis, though with most of these injections, there may only be 1 or 2 drops of blood, if at all. Not so common setup for the injections is when your staff has too much time on their hands and they decide to play with the equipment. Musculoskeletal injections are generally of joint, tendon, and or muscle. Again, the idea is to decrease the pain with local anesthetics and follow this with decreasing the inflammation, swelling, erythema with the steroids. We can also improve the lubrication of the joint with viscosupplementation, which is an artificial synovial fluid, a hyaluronic acid derivative. This is an example of injection of a painful lipoma. This is a benign fatty cyst or tumor, in this case under somebody's, on somebody's low back. And the idea here is to put some anesthetic and some steroid in there to shrink the lipoma down. The discomfort then goes away. This is an example of injection of a muscle trigger point. The trigger point is compressed. The area actually is cleansed, and then the needle is inserted into the trigger point. The anesthetic and the steroid is injected to decrease the swelling, decrease the inflammation, decrease the discomfort. This is an example of an enthesis, or ligament attachment to bone injection. This is marking out the bottom of the deltoid muscle at the shoulder. And here we would go to the attachment, painful attachment of the deltoid to the bone. Again, we would inject the anesthetic to decrease the discomfort and the steroid to decrease any swelling. the area then would be dressed sterilely. Often we have painful shoulders, and many of them are pain due to irritation, swelling, inflammation, or even partial tears of the rotator cuff. The rotator cuff is made up of 4 muscles: supraspinatus, infraspinatus, teres minor, and subscapularis. Here we have 3 of those muscles which attach to the proximal posterolateral aspect of the shoulder, of the humerus at the shoulder. And we can go down to the tendons and to the entheses, where the tendons attach to the bone again, and inject those areas. This is an example of injecting the shoulder from a posterior approach. The injection is placed inside the joint, coming through the back of the shoulder on an angle with the plane of the joint, and trying to place the needle in the center of that joint to get the best uptake of the medication and diffusion around the joint, within the joint. We can inject in and around the nerves to decrease pain. The idea here is to block sensory fibers with anesthetic and decrease painful sensation. If the discomfort is relieved, then there is greater ability to move the joint and greater interest in the patient to move the joint, because if it hurts, they don't want to move. It requires a knowledge of surface anatomy for nerve pathways, or the use of a nerve stimulator or ultrasound to localize to the nerve. A special category here has to do with migraine headaches. We have sphenopalatine blocks, and there are several different techniques to do these, either blindly or with imaging, such as ultrasound or fluoroscopy. The easiest to be done in the office is called a transnasal sphenopalatine block. Here, small amounts of local anesthetic are placed on a cotton-tipped applicator. They are inserted into the nose, through the nares, to a place between the superior and middle turbinates. The applicator is left there for about 15 minutes. The anesthetic migrates through the membranes and then is picked up in the projection of the sphenopalatine ganglion, which sits under the zygomatic arch or cheekbone. As the projections to the superior and middle turbinates are numbed up, that numbing action continues to the sphenopalatine ganglion, and that then reverberates to the head and will frequently break or markedly decrease the migraine headaches. Statistically, this procedure gives 70+% improvement in these headaches. Signs and symptoms of neuralgia include numbness and tingling in the distribution of a specific nerve. We'll see some type of pain, including sharp and burning and other dysesthesias, in the distribution of that specific nerve. Pain can be reproduced with palpation or tapping, also called Tinel's sign, on the nerve, but this is generally best seen for more superficial nerves. If we are looking at a motor nerve, we will generally see weakness in the distribution of that specific nerve. Two treatments, neurolysis and chemodenervation, are used for special neurologic upper motor neuron problem called spasticity. Spasticity is a hyperirritability in the muscle where there is a rate controlled increase in tone in the muscle. That is, if you stretch the muscle slowly, you can stretch the muscle out. If you stretch it too fast, the muscle will rapidly contract, and it will probably do that several times. Spasticity, however, will cause pain from pulling on the periosteum and from a buildup of metabolic waste products such as lactic acid within the muscles due to the increased activity in the muscles. Spasticity can block muscle action, which is under voluntary control in other muscle fibers or related muscles. This would decrease the functional retraining and potential improvement of the patient. So we need to look for spasticity in our patients with upper motor neuron lesions. Spasticity, because it restricts movement, will decrease the range of motion and thereby set up joint contractures or stiffness, tightness of the joints. This can be painful in and itself and may then be a stimulus to more spasticity. Neurolysis is a chemical destruction of a nerve branch to a specific muscle. We will often use medications such as phenol or absolute alcohol to do the neurolysis. And we require a nerve stimulator or possible ultrasound to localize right to the nerve so that we place the medication on the nerve and not diffusely in the area. Chemodenervation gets at the same benefit, but this is a treatment using botulinum neurotoxin to block the reuptake of acetylcholine at the myoneural junction, causing muscle relaxation. Here, we frequently use an electromyography machine to localize to the hyperirritable part of the muscle so that we can get the best take by getting the medication, the botulinum neurotoxin, into that most hyperirritable, most hypercontracting section of the muscle. This is an example of neurolysis where we are injecting the axillary nerve at the shoulder as it goes to the deltoid muscle. We have the syringe clipped to a stimulator. There's a black lead on the needle, and there's a red lead to a skin sensor, skin patch, to make a full circuit through the body. We use a stimulator such as this to connect to those electrodes. The stimulator is turned on and gives a low-level thumping through the needle to cause the nerve to fire, to cause the muscle to fire. The closer we get to the nerve, the less stimulation we need to get that muscle contraction. Once we're down at about 2 milliamps of stimulation, then we inject, and we know we are right on top of the nerve. We can put the anesthetic and anti-inflammatory medication right there. If we use this for sensory nerves, we do not look obviously for muscle contraction, but we work with the patient because we need to know that we are stimulating small electrical shocks in the distribution of the nerve to know that we are right on top of the nerve we are looking for. Physical therapy is frequently used to treat pain complaints. The idea, as many of you already know, I'm sure, is to improve physical effects of accidents and injuries, illnesses, and thereby decrease the pain complaints. So we're often looking at muscle spasm, that is tight muscles, not the hyperirritable upper motor neuron spasticity though physical therapy can treat the spasticity also. But spasm, joint contractures, weakness are primary areas to be addressed with our physical therapist. We'll use therapeutic exercise to improve flexibility, range of motion, strength, endurance, and functional mobility as walking, lifting, and carrying. As we improve the flexibility, muscle spasm decreases, buildup of lactic acid and other chemicals in the muscles decreases, blood flow through the muscles improves. As we improve the range of motion, we stimulate more synovial fluid to be deposited in the joints. We stretch the joint capsules out, and all of these activities help to decrease the patient's pain complaints. We'll use ultrasound, a superficial heating modality, to loosen joint capsules and allow for greater range of motion with prolonged stretching. We'll also use electrical muscle stimulation and TENS units to decrease pain complaints. TENS units, transcutaneous electrical nerve stimulation, will decrease the pain by blocking the sensory nerve fibers and breaking the pain cycle. The electrical muscle stimulation will relax the muscles and allow for greater flexibility. So what we're trying to do with this superficial stimulation is to decrease muscle spasm, increase muscle relaxation, and thereby decrease pain. This is a couple of examples of electrical muscle stimulation, transcutaneous electrical nerve stimulators. These are surface units. They usually come together with EMS TENS in the same unit currently. It used to be that they were separate units, but now we can get them both in the same unit and get effect from both the muscle and the nerve side to break the sensations and break the muscle spasm all at the same time. This is an example of an ultrasound unit with a wand that has a large circular head. This is passed over the joints, and in some units we can use them over the muscles to decrease muscle spasm and decrease joint contracture by relaxing and allowing to stretch out the collagen and elastin fibers in the capsular structures, allowing for the therapist then to stretch out the joints and for the patients to do their therapeutic exercise to a greater degree. Now, what we have talked about so far are the primary treatments for pain complaints. Next, we are going to talk about complementary and alternative medicine, or CAM. These are activities and treatments that are not mainstream, but have gained a great deal of utility. They are used throughout the country and around the world routinely to help treat pain complaints, but they are not yet considered mainstream medicine. So the treatments and techniques are used again to improve mobility and decrease in pain. These techniques include nutraceuticals, osteopathic manipulative medicine, medical acupuncture, and prolotherapy. Nutraceuticals have a history going back many thousands of years around the world. Over the last 50 years, there has been a progressive increase in interest in herbal medications, herbal medicinals, or nutraceuticals, natural occurring substances that have medical benefit. The National Institute for Complementary and Integrative Health supports research and has listings of what is known for many of these treatments. And it is open to people on their website. For instance, migraine headaches can be treated with butterbur, feverfew, magnesium, coenzyme Q10, and riboflavin. Musculoskeletal inflammation can be treated with turmeric, bromelain, willow bark, omega-3 fatty acids, devil's claw, ginger, and thunder god vine. Osteoarthritis is frequently treated with glucosamine and chondroitin sulfate. Osteopathic manipulative medicine is the treatment of a patient using manual approaches to them. Many of these techniques are very similar to the physical therapy techniques, but the intent here is to decrease muscle spasm, improve joint mobility, improve blood flow, decrease swelling, and desensitize peripheral nerve pain. There are a number of different techniques and paradigms within osteopathic manipulative medicine procedures. Some of the techniques include craniosacral therapy, which has been shown to be very beneficial for post-traumatic headaches. Visceral manipulation can improve GI motility and has been used as a treatment for constipation. There are direct techniques where the tissues, that is the muscles and the joints, are taken to an area of tightness and restriction called a barrier, and through one or another technique are moved through the barrier to release the barrier, decrease the tightness, improve the mobility, decrease the pain. Two of the more common use in direct techniques include muscle energy or contract relax. The contract relax techniques are the physical therapy techniques, but the muscle energy techniques are very similar to the physical therapy techniques here. There are also myofascial release techniques, concentrating on the fascial component overlying and controlling, tightening, supporting the muscles. There are indirect techniques where the joints and muscles are taken not towards the barrier, but away from the barrier and held in a position of total relaxation for approximately 90 seconds to allow the area to relax. This would be called counter strain. This is an example of osteopathic manipulative medicine to the low back for musculoskeletal pain complaints. Another complementary and alternative medicine approach is called medical acupuncture. Many of you, if not all, have heard of acupuncture. This Eastern healing art has been around for approximately 6,000 years, and in its current form, it has been around for approximately 2,000 years. We will use medical acupuncture for pain complaints in one of the medical acupuncture paradigms called neuroanatomic acupuncture. The idea here is to use the acupuncture needles to locally break muscle spasm mechanically. And we can do that by inserting the needles into and around the tightened muscle, or we can put a couple of needles into the tight muscle, the muscle spasm, and attach it to a stimulator. If we would put the stimulator at a low frequency, approximately 2 to 8 hertz, and as high an amplitude or as strong as the patient will tolerate, and leave that there for up to 20 minutes, we will break the muscle spasm and stimulate endorphin production. So the body will start making its own pain treating chemicals. Interestingly, we will also stimulate cortisol release from the adrenal glands, which is an anti-inflammatory chemical. So we get very good improvement in inflammation, pain control, and muscle spasm with low frequency, high amplitude medical acupuncture. If we would do high frequency, approximately 300 to 3000 hertz, but low amplitude, just to a light buzzing sensation, we can use this for chronic pain complaints, including, and or depression and substance abuse. This is because at the high frequency, low amplitude settings of the stimulating machines, we will actually stimulate serotonin production in the central nervous system. And serotonin is used for treating the chronic pain, depression, and substance abuse patients. And this is an example of medical acupuncture in an array of needles to treat low back pain. And this is an example of one of the stimulators that is used to stimulate the acupuncture needles with low-level electricity to obtain a greater analgesic and muscle relaxant or endorphin response. Prolotherapy is a technique that has been around for approximately 70 years. This technique injects a small amount of anesthetic and sclerosing substance, that is scar-forming substance, with the intent of causing localized scar. It is usually used to decrease hypermobility, that is overstretched joints or partially torn joints from chronic strain, enthesopathy, and weakened ligaments. The idea is to cause internal scar that will proliferate in the area of damage, and then scar will tighten down over the months afterwards, and thereby you get greater control over the joint movement, less hypermobility, less chronic strain, chronic irritation, and therefore you decrease the pain of the hypermobility. Now, I want to tell you a little bit about a research project that we ran, and then give you some things that you can take to your clinics at your next visit to help treat some problems. We were interested in knowing if any manual medicine or osteopathic manipulative medicine procedures could improve voice and possibly even swallowing. We have seen a number of patients with vocal dystonia, and the idea was, could we do something manually to help them out? So what we did was we looked at 50 subjects which were randomly chosen. We tested the cervical range of motion in flexion, extension, side bending, right and left, rotation, right and left, and then we recorded on speech analysis software 2 sounds, A, E, just like that. We then treated the patient with soft tissue osteopathic manipulative medicine procedures to the neck and the upper trunk, upper pectoralis, trapezius, rhomboids, cervical, thoracic, paraspinal muscles. We then recorded the speech again, and then recorded the cervical range of motion again. What we saw was that virtually every patient improved in most of the cervical range of motion pathways or angles. This was expected. We know that manual medicine can improve range of motion. That was our control. So we know we were doing something to the patient. What was interesting, however, was that over 80% of the subjects improved in the vocal parameters by analysis on speech performance software. The techniques we used are primarily myofascial release techniques or soft tissue stretching of the various muscles around the upper airway. So we were actually able to improve their voice performance. So the next step is that we believe that this should be done with a lot of patients, vocal dystonia patients, or just stroke patients, other patients that are having difficulty with speech. And we believe empirically that this should also help our swallowing patients. So we're recommending manual techniques to decrease muscle spasm and pain. And as a generic overview of several techniques I'm going to show you, we have some standards. Generally, the patient is supine on the exam table, and the therapist or doctor stands or sits at the head of the table. Always explain to the patient what you're going to do and why. Use gentle pressure, but not large force. When we move the muscles with our palpatory procedures, we move the muscles in a cephalad, caudad, or head to tail, anterior posterior, front to back, and anterior posterior or right to left rotation, or parallel to the or perpendicular to the fiber directions. And when we did this with these patients, it was all direct techniques, not indirect techniques. So we moved to the tightened barrier position. Never push to the point of pain, only to feeling the tightness and stretching in the muscles. We hold at that point and allow the patient to take 3 to 5 slow, easy, deep breaths, and the muscles then should relax. We repeat the process 3 to 4 times to get the maximum relaxation in the muscles. Masseter release. Again, the patient is supine. Therapist or doctor, sit or stand at the head and place the fingers on each side of the jaw. You compress the masseters and add pressure in an anterior posterior, cephalad caudad, anterior posterior rotation directions to feel the muscles tighten under the barrier. You hold as the patient performs several breaths to allow the muscles to relax. And each time you shift the fingers a little bit to tighten again and repeat. Repeat this 3 to 4 times to fully relax the muscles. Sternocleidomastoid stretch. The setup is the same, with the therapist or doctor at the head placing one hand supporting the head under the occiput and the other with the fingers behind the sternocleidomastoid. You compress the sternocleidomastoid and add pressure in anterior posterior, cephalad, and anterior posterior rotation directions to feel the muscles tighten to the barrier. Hold for several breaths, shift the fingers to tighten, and repeat 3 to 4 times. If need be, you repeat that on the opposite side. Do not come from the front of the sternocleidomastoid to avoid carotid artery pressure. The upper trapezius stretch, the setup is very similar. Again, you support the head with one hand under the occiput and place the other hand on the shoulder at the lateral end of the trapezius. Slightly flex the neck to tighten the trapezius to the barrier. Stretch the trapezius with pressure on top of the shoulder and with pressure on the head towards the contralateral side, the opposite side. Hold this for several breaths to allow the muscles to relax. As they relax, continue the pressure, aiding the muscle stretching. Repeat several times and repeat on the opposite side if need be. Platysma stretching, it's a little bit different. Patient is supine. Operator is at the head and places the fingers medial of both hands, medial to the jaw. That is underneath the jaw, medial to the jaw. You will feel the tongue more midline, and you are right between the tongue and the medial side of the jaw. You compress the platysma and add pressure in a cephalad direction and add a little anterior posterior and rotational component to feel the muscles tighten. Again, hold for several breaths. Shift the fingers to tighten again. Repeat approximately 3 to 4 times. Do not compress under the angle of the jaw. Keep the fingers towards the tip of the jaw. You do not want to go under the angle of the jaw because you want to avoid the carotid artery. You do not want pressure there. You also do not want to go in the exact midline. You want to avoid the trachea and larynx. Anterior pectoralis stretching is, again, the patient is supine, sitting or standing at the head of the patient, placing fingers on each side of the chest at the pectoralis muscles, just underneath the clavicle. Compress the pecs and add pressure in an anterior posterior, cephalad, caudad, and right-left rotation directions to feel the muscles tighten to the barrier. Hold for several breaths, allowing the muscles to relax. Shift the fingers to tighten and repeat. Do this 3 to 4 times. Maintain the hands at the top of the chest, superior to the breast tissue and superior to the nipple line. A lateral pectoral stretch, as the setup the same, but here we're placing the fingers on each side of the chest at the anterior axillary folds at the lateral part of the pectoralis muscle. You compress the pecs with the fingers from the armpit, inferior aspect of the anterior axillary folds, and add pressure in an anterior posterior and cephalad caudad direction to feel the muscles tighten to the barrier. Hold for several breaths and allow the muscles to relax. Shift the fingers in a cephalad direction to tighten and repeat. Again, 3 to 4 times to get full relaxation. Maintain the hands in the anterior axillary folds lateral to the breast tissue. Lower trapezius and thoracic paraspinal and rhomboid stretch is a little bit different. The patient is in the same position. The therapist or doctor is in the same position, but the hands are placed on each side of the upper chest from under the patient. So you're sliding your hands under the patient, along the spine, and to the right and left of the spine. You compress the muscles by adding pressure in an anterior posterior direction, cephalad caudad, and right and left rotation to feel the muscles tighten to the barrier. Hold for several breaths, shift the fingers to tighten, repeat 3 to 4 times. So the suggestion is to utilize these techniques to improve the vocal output and swallowing ability of the patients. I hope this session was of benefit and you were able to take some information back to your clinics, back to your patients, and to your colleagues. Again, speech and language pathologists are often first to find out that the patient is in pain. The help of the speech and language pathologist can benefit the patient by improving the knowledge of the physicians and the other therapists as they are trying to take care of the patient, but may not hear all the complaints firsthand. Thank you very much.